Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Today, we are putting a spotlight on a technology that's really changing how we treat blocked arteries in the legs. It's called intravascular ultrasound, or as you'll hear us call it, IVUS.
For the millions of people with peripheral artery disease, or PAD, the current standard of care, it often falls short.
Falls short how?
We're still seeing really high rates of reintervention and, some pretty severe complications. So if we're serious about saving limbs, the data is pointing us toward a new primary imaging approach.
Right. So our mission today is to really dig into the evidence that says IVUS is the critical tool for these peripheral arterial interventions. And maybe more importantly, why it's not being used everywhere despite the data.
Exactly.
Let's start with the current gold standard then. What is the fundamental sort of flaw with standard angiography that even makes us look for something else?
It really comes down to basic physics.
Mhm.
Angiography, which is the workhorse right now, gives you a two-dimensional X-ray, a flat picture. But these arteries, they're three-dimensional tubes. So you're essentially trying to figure out the true size and shape of a garden hose by just looking at its shadow on the ground.
That's a great analogy. So you're not just making a small guess, you're building in some systemic error from the very start. What does that lack of depth perception actually do in a procedure?
Oh, first, sizing. You have a massively limited ability to accurately size the vessel.
So for picking a stent, for example.
Precisely. You're trying to pick the right size balloon or the right stent, and you're basing that choice on, frankly, a hazy estimate.
Mhm.
If you undersize it, the stent won't press up against the vessel wall. That creates turbulence, blood clots.
And it fails early.
It fails early. And if you oversize it, you risk tearing the artery right then and there.
Okay, so sizing is a huge problem. What about the blockage itself, the plaque? How does angiography get that wrong?
It misses the important details. I mean, it can see that there's a narrowing, but it often underestimates how long the lesion actually is. And, more importantly, it can't characterize the plaque.
What do you mean by characterize?
I'm talking about calcium. How much calcium is in the plaque, where it is, how thick it is. That's vital information.
Why?
Because if a plaque is heavily calcified, it's like a rock. You need special tools to crack it or modify it before you put a stent in. If you miss that on the angiogram, you're almost guaranteed to have a poorly deployed stent or a complication.
Okay, and this is where it gets really critical for me. What about after the procedure? You think you've done a great job. Are there problems that angiography just completely misses?
Absolutely.
Right.
And this is maybe its most consequential limitation. Angiography has low sensitivity for diagnosing complications like an arterial dissection
A tear in the artery wall.
caused by the wires and balloons. Or you can't see if the new stent is poorly expanded or not quite flush against the wall. And if you can't see the problem, you can't fix it before they leave the lab.
So let's bring in the solution. How does IVUS, with its cross-sectional image, fix these problems in pre-procedure planning?
It's the difference between looking at that shadow on the ground and holding a detailed blueprint. With IVUS, a tiny ultrasound probe goes inside the artery itself.
Right.
And it gives you a full 360-degree view of the vessel wall. So for sizing, it's a complete game changer.
Let's focus on that because we know from heart procedures that accurate sizing is everything for long-term success.
It is. IVUS drastically improves your assessment of the true vessel diameter. This means you pick balloons and stents that are sized far more accurately. I mean, when experts rated these technologies, they consistently rated IVUS as excellent for sizing. Angiography, it was rated fair or good at best.
That's the difference between a device that works for years and one that fails in months.
Exactly.
And what about that hard calcified plaque that you said angiography misses? How much better is IVUS at mapping that out?
It's exponentially better. IVUS lets you see the plaque's shape, its eccentricity, and most importantly, the presence and thickness of calcium.
And knowing that lets you pick the right tool for the job.
The exact right tool. You can see where the thickest part of the calcium is and aim your device right at it. Without that information, you risk the stent getting crimped or underexpanded. It's the difference between success and an early failure.
So we've really shored up the planning and the sizing. But you mentioned those missed complications. How does the superior sensitivity of IVUS act as a quality control check at the end?
This is where it's your safety net. It's vital for detecting those immediate problems that angiography is just prone to missing. You can confirm the stent is fully expanded. You can verify it's pressed right up against the vessel wall.
No gaps.
No gaps where blood can get turbulent. But the real game changer is dissection detection. IVUS can spot even subtle tears in the artery that are totally invisible on a 2D angiogram.
And if an operator sees one of those dissections with IVUS, they can fix it right then and there.
That's the key. You identify it, and you can immediately optimize the result, maybe by placing another small stent or using a balloon. You prevent the late failure that would have happened. You're investing in the long-term health of that artery.
This all makes perfect sense in theory, but we need to see it in the real world. What's the hard evidence connecting IVUS use to better outcomes for these arterial patients?
And this is probably the most compelling part of the whole story. There was a massive retrospective analysis of Medicare beneficiaries between 2016 and 2019. We're talking about 500,000 interventions.
Okay, now we should note that retrospective data can only show an association, not direct causation. But with a study that big, what did they find?
That's an important caveat, you're right. But the association was just so powerful. They found that using IVUS was associated with a stunning 27% reduction in the risk for major adverse limb events, or MALE.
27%. Let's just pause on that. For our listener, MALE includes really bad outcomes, like the artery blocking off again or needing another major procedure. A reduction of that size it's huge.
It is huge. It means fewer emergency room visits, better quality of life, and just lower healthcare costs down the line. And it didn't stop there. They found similar, very significant reductions in the risk for major amputation. The hazard ratio was around 0.7.
So using IVUS appears to actually help save patients' limbs.
That's what the data strongly suggests.
Okay, that large real-world data set is powerful. But to really connect the dots, we need a randomized trial. What did the trial on the femoral popliteal artery show us?
That trial really drilled down on the mechanism of failure. They focused on restenosis, the artery re-narrowing over time, and they found that freedom from restenosis at 1 year was significantly higher in the IVUS group. It was 72.4%.
Compared to what in the angiography group?
Just 55.4%.
So a 17-point difference. That's a massive improvement. Why was it so much better?
The study tracked when using IVUS actually changed the procedure. And they found that it led to a change in the treatment plan in a staggering 78.9% of cases.
Wow. Wait, say that again?
78.9%.
So if you think about that for a second, in almost 8 out of every 10 patients treated with the supposed gold standard, the treatment was actually suboptimal or just plain wrong and had to be changed once they saw the real picture with IVUS.
The changes were mostly because they'd underestimated the lesion length or just miscalculated the device size. It confirms that relying only on angiography leads to errors almost 4/5 of the time.
And the 27% MALE reduction is the direct result of correcting those errors in real time.
That's the connection.
The evidence seems overwhelming. Which brings us to the critical question. If the data is this clear, why is the overall utilization rate for IVUS in arterial procedures still just around 11 or 12%?
This is where we run straight into the structural and financial inertia of the healthcare system. The biggest hurdle, especially in a hospital, is cost and reimbursement.
Let's unpack that a bit. Tell us about the DRG system, the diagnosis-related group, and why that system actually discourages using this better technology.
Right. So in a hospital, most procedures are covered by fixed bundled payment, the DRG. That payment is supposed to cover everything. The problem is IVUS uses an expensive single-use catheter that can cost thousands of dollars. When a hospital uses that catheter, they get no additional reimbursement under that DRG structure. Nothing. It is a direct, unrecouped expense.
So the hospital basically takes a financial loss on the procedure every time they use IVUS to provide better care.
Exactly. And that explains why use in hospitals is dismal. It's around 5%. But now, compare that to an outpatient setting, like an ambulatory surgical center.
Right.
There, the utilization skyrockets to around 40%.
And why is there such a huge difference?
Because the reimbursement is completely different. In that outpatient setting, using IVUS often gets a separate payment code, which makes it financially sustainable. The financial incentive is aligned with better care, whereas the hospital system actively discourages it.
That's a frustrating example of how finances can dictate clinical practice. We also see variation by specialty, don't we?
We do. Interventional radiologists tend to use it most, around 30%. Cardiologists and surgeons are a bit lower, maybe 15 to 17%. But that variation also points to some of the soft barriers.
Yeah. Let's talk about those. Training is the first one that comes to mind. How good is the training for peripheral IVUS?
It's severely lacking in standardization. I mean, operator comfort with interpreting the images is a hurdle. There's a survey of cardiology trainees, and only about 15% of them felt they were truly independent in using it.
So if you're not comfortable, even if the machine is in the room, you're going to stick with what you know best.
You're going to stick with angiography to avoid what you perceive as delays or complexity. And that perception of added procedure time is a real barrier, even if it's not always true.
But the experts say that with a trained team, the added time is minimal, right?
It's negligible.
Mm.
And what's more, when you use IVUS effectively, you often end up using less contrast dye and less radiation, which is a safety benefit for the patient.
So given all this, what are the most immediate needs? What do the experts say we have to do to make IVUS the standard of care it should be?
The consensus is pretty clear. We need specific guidelines and algorithms to take the guesswork out of it. First, we need a clear definition of what lesion severity on IVUS actually warrants treatment.
Moving from subjective to objective.
Exactly. Second, and this is critical, we need standardized algorithms for device sizing based on IVUS, just like they have for coronary procedures in the heart. And third, we need consensus on when to treat an IVUS-detected dissection versus when you can safely leave it alone.
And what about the training barrier?
We need standardized curricula, a mandatory minimum number of cases for fellows in training. And of course, we urgently need health economic studies to prove what seems obvious, that the upfront cost of the catheter is dwarfed by the savings from that 27% reduction in future limb-saving procedures. That's the data you need to change reimbursement.
This has been a really compelling look at a technology that is ready to go if we can just clear the structural hurdles. The core takeaway for you, the listener, seems pretty clear. For peripheral arterial interventions, IVUS is not a luxury add-on. It is a tool that consistently reduces error, improves sizing, and is associated with significantly better long-term outcomes, including that massive 27% reduction in major adverse limb events. It's the gold standard, just waiting for the system to catch up.
And if we look to the future, given how hard it is to standardize training across different specialties, which is a slow process, the industry really has to explore a technological shortcut. I mean, could we successfully develop artificial intelligence AI to reliably interpret these complex IVUS images?
To give guidance in real time.
Exactly. If AI could sort of democratize the interpretation, it could massively accelerate adoption and ensure consistent decision-making, even while the formal training pipelines are still trying to catch up. That might just be the next great leap in patient safety.
A truly provocative thought to end on. The pressure is on to get patients the care that the data so clearly supports. We encourage you to explore the data for yourself. We'll see you next time.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.